If everyone could mute their lines if they are not speaking, that'd be really helpful. We're getting some background noise. Thank you.
And Ryan, it looks like folks are still connecting to audio, so we're going to wait for another minute. Welcome, everyone. I'm going to give folks a minute to connect to audio. All right, looks like most people are in, I think. Is that what you see, Ryan, as well?
Absolutely.
Okay, great. All right. Good morning. Thank you so much for joining us for our weekly media briefing with the Washington State Hospital Association and its members. We're very glad that you've joined us today. We have a number of things to talk about. I want to begin, I'm sorry, I'm Cassie Sauer. I'm the CEO of the Washington State Hospital Association. And I'll begin by introducing our panelists today. We have Dr. Ken Dietrich, who is the Chief Medical Officer of Summit Pacific Medical Center in Elma, which is a rural critical access hospital. We have Shane McGuire, who is the CEO of Columbia County Health System in Dayton, Washington, which is in the center of the state, also a rural hospital. And we have June Alteras, who is the Senior Vice President and Chief Quality Safety and Nursing Officer at MultiCare Health System. And June is a nurse. We're really glad to have all of them here with us today. So I'll start with some opening comments. First is that we continue to see a decline in COVID cases in our hospitals. So we are really, there's a number of things in the chat. Let's see what the chat is, just a second. Hang on a moment. Ryan, can you give folks permission to record?
I think it's a setting we need to do. Ryan, if you can walk me through it, I can do it if you aren't able to.
We are currently recording, and just give me a moment, but feel free to carry on with the media brief.
No, they're trying to roll on it right now. They're on something, and Zoom won't let them without us giving permission.
Okay, I'll definitely, I'm jumping right in right now. So thank you all for your patience.
All right, we're just gonna pause for a minute because otherwise we'll just have to say the same things again. Ryan, let us know when it's good to go.
Yep, thank you very much.
Okay.
Okay, unfortunately, this meeting was set up on Beth's account, so I do not believe I'm going to be able to get into her settings.
Beth, can you change it on yours?
Sorry, guys. Can you walk me through this, Ryan, please? I'm in. I can do whatever you need me to do.
Okay. Great. So I'm just going to, one second here.
Or if anybody on the media knows how to do this quickly, you can tell us too.
Okay.
I think we've set it up this way before, but somehow the setting got mixed up today.
Okay, one second here. Okay, we're going to manually allow people to record Cairo 7.
Are you able to do that right now?
Yes.
Okay, awesome.
Okay, Cairo.
Yeah, I would go through King 5.
Yep.
And pretty much go through the list and just make it so anybody can record would be great.
Mm-hmm. And the settings towards King 5 and Cairo should be confirmed. If you could confirm on your end, that'd be great.
But Ryan, I think we want to give it to everybody.
Okay, yeah, I'm gonna do that right now.
Okay.
You're just gonna run down the list.
Mm-hmm.
And if King 5, while you're on, can you just confirm that that is working while Ryan's going through and doing everybody else's? Sorry for the technical difficulties, guys.
We're a little bleary-eyed from spending our weekend working on counterfeit masks, which we'll talk about. Great, Allison says it's working for Cairo 7, thank you.
Wonderful.
All right, does anyone need me to reintroduce our panelists? You put that in the chat if you do, otherwise I'll just keep going. Okay, it looks like it's working for a lot of people. Okay, I'm not going to reintroduce our panelists, but if you want me to do that, put that in the chat. Okay, so I will begin again by saying that we continue to see a decline in COVID cases in our hospitals. We are really pleased about this, really pleased with Washingtonians' efforts, that they are continuing to wear their masks, to social distance. We are worried about the Super Bowl. I keep saying we weren't thankful for Thanksgiving. We don't think the Super Bowl is super. We're hoping that in Washington State, we don't really watch the Super Bowl that much because we don't like Tom Brady. So we're thinking that people might not have wanted to see that. So maybe my family watched the Puppy Bowl instead. So maybe people did that, stayed home and watched dogs on TV. The big news of the weekend, obviously, was the counterfeit masks. I actually have some here. Here's one right here. You can see that it has the 3M marking on it. It is we keep saying it's a very good fake. The head straps are great. They're secured on very nicely. The inside looks just like it's supposed to. It has the metal bar across the top and the nose. This is a little nose. What would you call this, June? Kind of just like a little piece of foam that keeps your nose from getting banged up, I guess. The metal bar on the top. Anyway, you can see that.
Protects skin, because when you wear it for a long time, it gets rough on the skin.
Yep. So this is looks like an excellently made mask. It looks like 3M. It has all the stamps and labels that 3M put on their masks. We know that Washington hospitals have acquired hundreds of thousands of these. Many of them have not been used. The Hospital Association, for example, purchased 300,000 of these masks. We know that at least 60,000 of our masks remain in the warehouse, so they never even got shipped to a hospital. We've gotten confirmation from quite a few hospitals that they hadn't used them at all. Some other hospitals have used them, and they're trying to determine how many and when and where they were used. It is incredibly disheartening, really, really frustrating to discover that we have these masks. And Shane McGuire, for example, is someone who his hospital received masks from the Hospital Association. They were able to locate them over the weekend. They had not been used. So you can ask Shane about that, but it's a real mixture of ones that have been used and have not been used. One thing we have heard that is encouraging is that, well, again, 3M did not make these masks. There has been no increase in COVID cases from hospitals around the country where staff have been wearing these masks. And as I showed you, they're really good looking masks. They look, they feel, they fit, and they breathe like a 3M mask. We don't know enough about them to say. People keep asking us, how protective are they? And we don't know the answer to that. But we know that they're really good fakes. We are going to be involved in ongoing conversations with Homeland Security, with 3M, the legal and supply chain teams from the Hospital Association, and a number of member hospitals have a meeting today at noon with 3M to talk about what they do going forward. We're really grateful for Homeland Security's work on this and for the work of 3M. They have an extensive fraud department. We have all learned a lot about PPE fraud over the last several days. It is a huge crime. I mean, there's a lot of people doing this throughout the world trying to pass off masks, and especially 3M masks because they're in such high demand to organizations around the country. And so Homeland Security has confiscated millions and millions of fraudulent masks in 2020. They're continuing to do that, and I think they're going to be a really helpful partner for us moving forward. So with those opening comments, I think I'll turn it to Shane just to give you comments on how are things looking in Dayton. For folks who are not familiar with our state, Dayton's right in the middle of it, quite a rural area. Maybe you can give some description of that and the size of your hospital and what you're seeing on the ground.
Yeah, hi, this is Shane McGuire with Columbia County Health System, Dayton General Hospital. We're actually in the southeastern Washington corner. We're the second least populated county in the state. I think it's like 4 people per square mile. Our hospital district actually covers part of Walla Walla County. And so what we look at from the COVID perspective, our role is to obviously maintain and take care of our local communities, but also to act in a supporting role for the larger hospitals in the area, Cadillac, Providence, St. Mary's, Trios, for example. We work really hard to keep their beds empty of skilled nursing patients so that the higher acuity patients can be kept there and keeping their beds available. We do have a nursing home attached to our facility. We are very, very thankful that none of our residents have been exposed to COVID. We've had no deaths in our nursing home from COVID. We have had 3 employees that had exposures outside, but for the most part, we've been doing really, really well with maintaining sort of the quality of care that needs to be regarding COVID specifically. I think one of the things that we're frustrated with quite extensively right now is the vaccines. The supply is just not there to meet the demand. I think pretty much every hospital can tell you that across the state that there maintains frustration. There seems to be frustration around that. I can also say that we're doing what we can to sort of address the mental health issues associated with COVID, years with the lockdown. And so we think it's one of the areas that have been sort of under the radar that I think we're going to have to deal with a lot through 2021 is maintaining good mental health for our communities. So yeah, as far as the counterfeit masks, I think the thing I can state and reiterate over and over again is that the counterfeit PPE has been around since COVID started, really. It's not a new issue, it's an ongoing issue. I think we're all very careful and try to check our sources and be very wary of it. But I think the gist of it is that the easier frauds to detect are started going away, and now you're starting to see a lot of better construction and a lot harder to detect PPE. We're fortunate. We were after really the small N95s. That was what was intriguing to us, and we were able to pull those before they made it out into the staffing. So yeah, that's the update from Columbia County. Thank you.
Thank you. How about June? Let's hear how things are going at MultiCare.
Hi, good morning, Cassie. If you're not aware, MultiCare has hospitals on both sides of the mountains. We have 7 adult hospitals, 1 children's hospital, and 2 inpatient behavioral health hospitals. Our hospitals remain very full. It is still respiratory season. However, only 11% of our beds are filled with COVID positive patients. At our highest point, we got very close to 22%. So we continue on a downward trend. So that's really good, although our hospitals are still very full, and that's typical for respiratory season. We also have the counterfeit masks, and they were in use in our organization. We are very fortunate that last spring we made a strategic decision that we were going to broaden what types of masks we stocked as we could and work with different suppliers. So fortunately, we had a different mask to switch out for our staff. So we spent the weekend collecting the counterfeit masks, switching out to a different mask, and fit testing our staff. We are recommending to our staff that if they took care of a COVID positive or a rule out COVID patient within the last 14 days, they receive testing. Of course, we will do that, provide that for them. And even if they didn't take care of someone, if someone just really feels that they want to be tested, we will also support them in that decision to be tested. So that's all starting today.
Thank you, June. I appreciate that. And that's, I think another thing that's happening in our hospitals around the state, including from MultiCare, is there is a number of hospitals have offered to resupply the hospitals that have the counterfeit masks if they don't have enough masks. And so far, everyone's okay, but we've appreciated we continue to be so just gratified by the collaboration among Washington state hospitals. And in this is another great example of hospitals being willing to help others resupply. All right, Dr. Dietrichs, how about some opening comments from you?
Thanks for the invite. So Summit Pacific is a critical access health system focused really on primary care, and we have an inpatient unit as well. We have been actively screening for COVID for some time, and that program continues to operate and been very well received. We have a drive-through testing center that continues to see probably the average number that we've been seeing over the last few months, so anywhere from 30 to 60 patients a day. We have been actively vaccinating for a month and a half, and unfortunately this last week we've received no vaccine allocation. Over the last 2 or 3 weeks, we've been actively working with our county health department and Grace Harbor Community Hospital and stood up a mass vaccination program, which we brought online through the health department a week and a half ago, and that's ramped up and has been very successful now, able to do probably up to about 1,500 a day. But again, waiting for the vaccine allocation. One of the things that's interesting in our county is we have developed for our county, both the hospitals and the county level on websites, a way for patients to sign up if they want the vaccine, to get information so we can prioritize them based on what phase we're in. And we have a very high percentage of eligible individuals who want to get vaccinated, which is great. So I would say that overall, in our region, we continue to see regularly COVID positive patients every day. We continue to admit those who needed to be admitted, working with the health department to quarantine those who are outpatient based. And then the biggest push now is vaccination.
Thanks, Dr. Dietrich. I think an important thing to note about vaccines this week and next is that hospitals and other vaccine providers used a lot of second doses as first doses. In the third week of January, the governor told all vaccine providers that they had to use all their doses within a week, all the doses they had received within a week. And so that included second doses. So second doses got used as first doses. And so now we are having to use some of our first dose allocation as second doses for those second doses that were used as first doses. This is very confusing, but I hope that makes sense, and I'm happy to answer questions about it. So this week and next week, we think there's going to be a lack of first dose appointments available in our state because everyone is prioritizing finishing their second doses. I think in 2 weeks from now, we'll be done with the second dose backfilling, and also the federal supply is supposed to go up. So we're hoping that in 2 weeks from now, so sort of in mid to late February, there will be more first dose appointments available for those in our B1 category. And Dr. Dietrich, you also you volunteered at the mass vaccination clinic, is that correct? You want to tell us a little bit about that?
Yeah, so I think it was a week or so ago, Friday, one of the vaccination days, which here in Grace Harbor, it was being held at the port, has provided a very large warehouse space that they typically have used for offloading cars that are being shipped in. And the county developed a really great system, and it was manned almost exclusively by volunteers and continues to be done that way or operated that way. So I worked on a Friday, went down, it was fun. The way they set it up was that cars, at the time we were inviting 100 cars per hour to come in, and they would come in and park them in a line of 6, and then the next line would come in 6, and there would be one of us assigned with a cart to each row, and I would go and vaccinate the individuals in the car in the first row, and by the time I was done, the second row was already there, and I just walked through the rows. By the time I got to the 5th row, the first row had been refilled, and we were able to quickly vaccinate 100 individuals within 20 minutes. So since then, we've been ramping up and continue to operate with volunteers. It's, I think, a compliment to the community, and I suspect across the country the same experience that so many people in the community are volunteering, including retired nurses, retired physicians, providers, others coming forward, and it was kind of a fun day. It's not often that every single person you see is thankful that they're getting a shot. So the individuals in the community were very happy to be there, and just more folks wanting to be invited. One of the things that we did, I think, that was that helped us overcome a lot of traffic issues is we have this big list of people who want to get vaccinated, and we would call them and schedule a day or two before, not a week or two before. So it was really dependent on how much vaccine we had. And then as part of the process, we had a list of who those were, and the first triage at the gate would check to make sure that they were on the list. So we didn't have large lines of people hoping to get vaccinated that have to be turned away. And overall, it was a really successful program and a lot of fun.
Great, thank you. Okay, so now we are open for questions, and we have one from Allison. Is 3M one of the most popular because of fit? Yes. They fit really well. They fit a lot of people, and they come in different sizes. They come in a small size, and Shane noted they were looking for a small size. They fit a lot of people, but they especially fit women's face as well because they come in the small size. That's another question. Are 3M more popular with certain healthcare workers, men and women? I think everybody likes them. June, please jump in here, or Dr. Dietrich, but I think women, they are especially good for women because they are the small size.
Of the options, the 3M has been the most popular with our clinicians and others. It's been very challenging to find N95 respirators that fit people with particularly small faces. And the 3M 1860S is the one that we've had the most success in fitting people with small faces, because that fit is what's so important. It has to fit. It has to have a seal where nothing escapes around that mask. It's very important in these situations. And so the 1860 small has been our most successful mask for our clinicians out there. So we had them in many, many places. I think that across our hospitals, we took back masks in over 500 different departments. And so they were broadly utilized across our organization.
So June.
And I would add that the 3M product has been used for many years, so this isn't something new just for COVID. And so the hospital staff are very comfortable and knowledgeable about using it, and it's another reason why it's so popular. So there's a lot of confidence.
And one other thing that is really important is the 3M N95 respirator. It gives moisture barrier, which is required in all of our perioperative spaces, procedural spaces, and when you're doing an aerosol generating procedure with a COVID positive or suspected patient. So they offer that moisture barrier, which other N95s do not. So the substitutions we're making, our staff in those situations do have to put a surgical mask over top of it to provide that moisture barrier.
Thank you. Another question is there any evidence they don't work as well as the actual 3M masks? We don't know enough about them to answer that question. And is there concern for safety of healthcare workers who use the masks? So far, the data that we have seen does not show an increase in COVID cases among our staff. However, as June noted, the hospitals are offering testing to anyone who's been wearing these masks. So I think this remains a situation we don't know a lot about. I'll show you the mask again. I mean, they're really good. They look really good. It doesn't mean we're going to keep using them by any means, but they have fooled everybody. We only heard about this from an alert, but staff who've been wearing 3Ms, as Dr. Dietrich said, staff who've been wearing these masks for years wore this mask and didn't feel any difference. People steal 3M specs and then go manufacture exactly to their specifications. We don't know if that's what happened here, but that's a hot business to since 3Ms are so popular to work for 3M, steal their specs, and go make the exact same mask. Again, we don't know that that's what this is, but just that is something that happens. Anybody else want to comment on that?
I would just add, Cassie, that the good news is many of our staff have been vaccinated, so that's really good news. And within MultiCare, the other piece of good news is that in January, the positivity rate for our staff is the lowest that it's been since May. And in addition, of course, we're offering testing to our staff to be certain. But at the end of the day, we just don't know.
Great. There's a question about, do we have any plans to test the fakes to see how well they might have worked? I don't know that we could do that. I'm not sure if anyone, we've just been working this weekend to get them off the shelves. Does anyone have comments on that about how they could be tested to see how well they work?
I'll just jump in on that. I think testing these would be difficult for a hospital system to do because you're gonna need to have some viral-like particles or virus to test in some kind of a controlled situation. So this would be more of a research aspect in a lab that manufactures these types of things and validates them as being adequate, and not something that the hospital could do. Globally, hospitals could report how many patients or staff have used them, and then you've already indicated the infection rate to suggest that they may or may not be effective, but the actual testing would not be something that we would normally be able to do.
Thank you. That's helpful. Question of, do we know who made these masks, who the vendor at fault is? We don't know who made these. We don't know that they're in the supply chain. And it looks like a number of distributors got them. who made them is unclear. I think this is something that Homeland Security is going to be working on. That's, you know, as I said over the weekend a number of times, our part of this is to get them out of circulation and to cooperate with Homeland Security in their fraud investigation and looking at where, you know, what can they find out. I think we're not investigators of international mask fraud, so I think we'll be turning over turning over any of the masks that Homeland Security wants to them. Let's see, June, another question for you. Can you help us understand how frustrating this is with all you're doing to keep employees safe, that someone would risk putting them in jeopardy to make money off fake masks?
Well, I will say, to quote one of my colleagues, Cassie Sauer, there's a special place in the afterlife for people who would do this. I will tell you that second only to the devastation to patients and their families that are impacted by COVID has been, over the last year, trying to help our clinicians and staff decrease their fear and anxiety, and to have to reintroduce fear and anxiety to our clinicians who are out there taking care of their communities because someone chose to try to make money off of this situation is really highly frustrating. These clinicians have been through enough. This is really very disappointing.
We were all, I will say that anger level over the weekend was incredibly high. I just, it's reprehensible. It's depravity. We're horrified. Okay, I think that's all. Let's see. Oh, wow, a bunch of, I think that may be all the questions at the moment. Oh, there's questions about how many masks there are. We don't know the answer for sure because we are still working with 3M to determine the extent of the fraudulent masks, but we think it could be somewhere in the 2-ish million masks that may be in circulation in Washington, or not in circulation, may have been acquired by Washington State hospitals. 300,000 of those were acquired by the Washington State Hospital Association. There was a question, did we believe we were purchasing the masks from 3M? Yes, we definitely believe we were purchasing. I mean, 3M makes them, they get the distributors buy them, distributors distribute them. So we bought them from distributors. We absolutely believe they were 3M masks. And we received a notice from Homeland Security on Friday about this. Beth, maybe we could email out to everyone the Homeland Security alert that came in on Friday, because it lists all the lot numbers. That might be useful to people. I think I'm sort of looking through the questions to see. I think if anyone would like to ask a question about the masks, I was going to move on to some questions about vaccine. Anything else about masks? We also can provide you photos of these masks. If you'd like to have a photo of them, we can, we've been providing those to some media outlets. Happy to do that. What is our confidence level going forward? This won't happen again. We have actually placed another order for masks. We have been able to order them directly from 3M. So if we're getting them directly from 3M and not from a distributor, our confidence level is high. We've ordered 1 million masks. They've agreed, in light of this fraud, to expedite that order. So we're hoping that it will, those will come relatively soon. You know, I want to have high confidence it's not going to happen again. And also, I think people are looking for, you know, there's sort of grafters out there looking for a way to make money. So we are going to do everything we can to make sure it doesn't happen again. But I feel like, as Dr. Dietrich and Shane said, that the frauds are getting better and better and better. They're harder to spot. And so that's quite worrisome. There's a question about, is it our expectation we'll be able to recoup some of the money spent on fake masks? We don't know. As I said, over the weekend, we spent all of our time working on getting the masks out of circulation. This week, our legal teams are going to be meeting together to try to figure out if they can recoup any of the money. But we don't know yet. I think the distributors are trying to figure out as well too how they got in their supply chains about what kind of refunds they'll be offering, but we don't have any definitive information. June, you don't have any updated information about that, do you?
No, we don't. We'll be participating with you on that call at noon.
Yeah. So there's a lot, we can talk more about this next week too. There's a lot to be learned. Looks like we sent out the pictures, but they didn't go. Okay, so let's move on to vaccines. So there is a question about, in retrospect, was the governor's directive that hospitals had, or vaccine, not just hospitals, vaccine providers had to use all their doses in that week in January, including second doses. Was that problematic? And I think, yes, it has proven to be problematic. The state, I feel confident the state is going to address this. They have given the second doses. They've given second doses for the second doses that were used as first doses. So they're working to rectify this. I know MultiCare was an organization that needed a bunch of second doses and got them over the last week. So 6,000, I think, received. And you got more this week too? Is that right, June?
Well, actually we've received less vaccine week over week over the last 3 weeks. We're assured by the state that we will get enough vaccine at the end of the week to administer second doses next week. So we're hoping that happens, or we will be placed in the unfortunate position to cancel people, which we've been doing everything within our power trying to guess how much vaccine we'll get to avoid cancellations. So we're hoping we actually get those doses at the end of this week.
Yep. And so far, Shane or Dr. Dietrich, you all have gotten, it's been anxiety provoking, I know, quite a nail biter every week to know if you're going to get your second doses, but I believe they are coming. People have gotten the second doses they need. Is that true for both of you as well?
This is Shane. Not necessarily. We've received primary doses that we've ended up using the secondary. I mean, the vaccine quantities we receive in rural are like 100 doses. Like 1 week, that was our entire allocation was 100 doses, and we had 70 seconds that we needed to do. It was listed as a primary, and we use it as secondary. And so we're having to sort of think on the ground, on our feet to get it done. I could definitely say that the use your vaccines within 7 days is a very, very problematic rule because it sort of takes inventory management out of our hands and kind of puts us in the situation that we're in right now. I could also say that, you know, in general, rural kind of getting lumped into large counties, you know, especially when you talk about mass vaccination clinics or something of that nature, it's hard to mobilize an elderly population, drive an hour and a half away and wait in line for a couple of hours at a mass vaccination site in the Tri-Cities. We'd really love those inventories kind of in our community so that we can dose close to home and maintain and be given the opportunity to maintain that inventory responsibly.
I will say one thing that we saw last week was people made first dose appointments by going into scheduling systems and saying that they were getting a second dose. And so then they, just as a way to get into the system. So when they showed up at some clinics saying that they were there with a second dose appointment, but not having received a first dose, in many cases, they were turned away. So we would really encourage people not to do that, to not make a second dose appointment that's actually a first dose appointment. Let's see, there's a question in Spokane, and I suspect other places decreased allotments of vaccine doses to hospitals. But a lot of our big providers did not get first doses last week. Is the Hospital Association working with DOH to ensure that hospitals can keep offering doses at the level they are able? Hospitals could be offering thousands and thousands more vaccines, tens of thousands, maybe even 100,000 more vaccines a week than we are currently receiving. Nobody has enough supply. Everyone wants more. The community clinics want more, the pharmacies want more, hospitals want more, long-term care wants more, the mass vaccination clinics want more. So we are hopeful the federal supply will continue to grow. If the Johnson & Johnson vaccine is approved and is on the production schedule they have advertised, that will certainly increase the number of vaccinations pretty dramatically. And an important thing to keep in mind about Johnson & Johnson. So if you do 100,000 doses of Pfizer, you have vaccinated 50,000 people. If you do 100,000 doses of Johnson & Johnson, you have vaccinated 100,000 people. So that's a really big difference when you look at the number of doses received, that you actually don't have to cut that in half. Feel free to put questions in the chat or ask them orally. So we're going to send you the Homeland Security release and the photos. Evan, data management, do you mean you're about the data entry into the immunization information system? Yes, vaccine administration and distribution data. Yes, yes, it remains a problem. We are as we have put on our website information about how many doses hospitals have administered. We've also asked hospitals to give us information. Like we asked a question this week about anything else we need to know as we talk to policymakers and the governor's staff about vaccines. And we got, I'm actually trying to find this real quick. We got several comments from organizations that said they are still baffled by what's happening with the immunization information system because they have inputted 3,000 records and it shows that they've put in 10. Many organizations it is working okay, so maybe we could have a little go around, and it's a little mysterious about why it does or doesn't work. So June, you all have connected yours with your EHR and that's gone quite smoothly, right?
It's gone smoothly on our end, uploading into Waze, although there are still discrepancies that show, and it may be why we've received decreased allotments, is that the state shows we have a lot more vaccine on hand than we actually have. We'll be out this week. So it works easy for us, but there's some sort of disconnect on the other end of Waze that have pretty big discrepancies.
Dr. Dietrich, how about you?
I would say the same. We have it integrated with our EMR and we've been submitting it. One of the biggest frustrations over the last month is the multiple times the reporting has changed and who do you report to and how many ways. But we also have found the same thing with the number of doses we've had and what's been posted after reporting it. So there seems to be, needs to be better work and validation on the receiving end.
Shane, how about you?
Yeah, we're actually all manual. We don't have any integration at all into our EHR. And so the interesting thing about manual is that it seems to get into the system faster and more accurately. There's not a computer interface and there's no backlog between us and the WAIS from that perspective. It's just incredibly manually intensive when you're doing that data over and over again for all the required reporting agencies. Because again, for us, you're redundantly putting it into several systems.
And just to clarify what Shane is describing about manual entry, you're not entering into the system, we vaccinated 200 people. You are entering into the system, we vaccinated, John Jones and Sally James and their birth dates and their addresses and which vaccine they received. So each human has to have a very full record created for them. And some of whom are already in Waze, but some are not. And some of whom might have might use are you Ken Dietrich or are you Kenneth Dietrich? And so you've got to look up and figure out which, who they are. Sometimes people fill out the forms and put today's date instead of their birth date. And so a lot of hospitals have found that if you're doing that manual entry, you need to be doing it as people are sitting in front of you so you can verify the information. They might have moved since they last had a record in Waze. So I don't know, Shane, if you want to add any more about that, but it's very labor intensive. As we mentioned, the Swedish CLU site has 2 data entry people for every vaccinator, and maybe others of you could describe how you're doing that too. Like what's your ratio?
Yeah, I mean, we partnered with public health and that's exactly it. There's literally a team of people doing the data entry for each person receiving a vaccine. So very manually intensive, but once it's in the system, it's usually in the system pretty solidly.
Dr. Dietrich, can you talk about at the mass vaccination site, how you did Waze entry and also what you did about second doses?
Right, so in terms of the first question at the mass vaccination site, it's all being done manually. And luckily we have a lot of volunteers, so it's either 1-to-1 or 2-to-1 ratio for one immunizer, 2 individuals volunteering and getting all the information loaded as people come through, and by the end of the day, everybody's loaded. So when the patients come in, there's a form that they fill out that gets checked by another person to make sure it's accurate, and then that information, once the allocation, the coding with the specific immunization lot number that they receive gets loaded. So that's very time intensive in terms of that. In terms of the second dose, when the governor's directive came out to give all of the doses that you received in the first week, we interpreted it a little differently at Summit because we also had a pledge prior that the governor has given that if you give a first dose and you record that, then they will automatically send you that second dose. So we interpreted the message that we were obligated to give our first dose allotment of vaccines within the first week, but we did not use second doses for first doses. And therefore, we've been able to keep up on our second doses, which have been scheduled out. The vaccination center, none of those individuals are ready for second doses. I think this coming Thursday will be the first set of those. And we're waiting to hear whether or not we're going to receive those second doses.
So have you, when people get their first dose at a mass vaccination clinic, do you schedule a second dose appointment, or do you just tell them to look again in 3 weeks and try to find one?
We actually give them a schedule. We get their contact information, and then we let them know that we will be calling them and checking back to reconfirm that close to the date to make sure, oh, remember that you're coming, but also that we have the vaccine.
Thank you. All right. Is anyone using PrepMod? I don't actually know if it's what its status is in the state right now. Okay. Evan, there may be some who are using it that just aren't on this call, but I have not heard that. That'd be a good question for the Department of Health. State data seems to be missing quite a bit of race and ethnicity data. Any insight on why that's the case? For those of you who are doing manual entry, are people willing to answer the question? Anyone?
Yeah, I think from our perspective, it's the state system is very particular on how that data is entered. And so if you're not using the right nomenclature, it doesn't receive it or it doesn't accept it. And so for us, we just, it's a lot of training to make sure that the right entries are put into the system so that the state system will actually accept what you're putting in there. At
our mass vaccination site, I don't think that's being asked. I have to go back and look at the form. But because we're trying to do it very quickly, we're trying to gather the minimum amount of information that's required. So I'm not 100% sure that that data is actually being recorded at our mass sites and therefore would not be being reported.
That's one of the state-operated mass vaccination sites, is that correct? Or county-operated? State?
Right, yes.
Okay. And June, how about you? You all use people have to register through your electronic health record, right?
Yes, I'll say that I don't know the answer. I can say that it has been something within healthcare for years and years and years that we have tried to get better race and ethnicity data. However, sometimes people don't identify with the options we have for them. Sometimes people are uncomfortable answering those questions. And in addition to that, if to Shane's point, if it's not entered exactly the way Waze recognizes it, it spits it out, for lack of a better word. And so that could also be one of the many reasons for inaccuracies.
We have a number of staff who've been volunteering at clinics, including Bess Zabrowski, who's here, and she has been a data entry person at the Swedish mobile clinics, and they are entering it, but she noted that if you don't save it properly, it gets lost. It sounds like I think it's a bit of a tricky interface. Beth, anything you want to add about that?
I think when you're using volunteers and you're trained rather quickly, and the software is very particular about how you save things. You have to click certain things. Oftentimes at these mobile clinics too, they're using some kind of a mobile internet, and you're trying to keep up with the people who can put the vaccines into people, and I think sometimes those internet gets really slow and the system cacks out. So it is tricky, but I think that people are trying to do the best they can to get that information in. I know that certainly at the Hospital Association, we have a huge focus on equity and trying to get into communities and making sure that people who may not get access very easily, who might not be the most computer savvy, get access to it. So that's really important to know if we're having the impact that we're trying to have. But it's tough as a data entry person, especially a person who doesn't do that all the time.
Thank you. I think as we've said before, the giving of the shot is the easiest part of a vaccine clinic. It's all the parts around it that are hard. We have been working with our member hospitals to identify strategies that are most promising for addressing equity in vaccines. And some of these are things like mobile clinics that Swedish is doing, calling and offering people appointments rather than having them have to go through an online portal, because that really advantages the most technologically savvy. Having them be much more geographically dispersed. As Shane described, we are concerned that we could be losing access to vaccines for some of the most frail people who can't drive, or people who can't drive, who don't have a car, or who can't drive that far, or who can't stand, sit in a car or stand in a line for 2 or 3 hours to get a vaccine. We would like there to be smaller opportunities, easier to navigate throughout the states, that people can be guaranteed, you have an appointment at 11:30, you're going to walk in and get out and be seen and get out and have a comfortable place to sit that's close to your home. So I think those are some important things. Working with community partners, thinking about using navigators who could go to a community partner site and help them sign up and help them get the online appointments if that's the appointment strategy, and even giving preferential access to certain zip codes or certain community organizations. There's lots of great zip code and census block mapping that you could say, we're going to run a vaccine clinic for people who live in this zip code this week, and really target some of the communities that have been most impacted by COVID. So those are among some strategies that we are looking at and sharing with members. Another question: with Johnson & Johnson coming online, hopefully, yes, hopefully, and with its different qualities, how will hospitals prioritize who gets what vaccine? I think we don't know this for sure, but I think we think the state is going to determine who gets what. And I would guess hospitals are more likely to keep getting Pfizer and Moderna because we've got the storage for it. And that the Johnson & Johnson may go more to the mass vaccination sites. That's a guess. That'd be worth asking Department of Health, but it's been my supposition that hospitals probably won't get a lot of Johnson & Johnson. Anybody else think about that? Have comments about that?
We don't know, but we're supposing that Johnson & Johnson will enable this more dispersed, decentralized methodology, because the vials are single dose vials and they're stable in a normal refrigerator. So much easier to take these out into people's homes and all the types of things you were discussing, Cassie. So we're guessing Johnson & Johnson will go much more broadly to much smaller businesses, entities, come into Safeway and get your vaccine, because of the stability of Johnson & Johnson, and single dose vials makes it much easier than the storage requirements of Pfizer and Moderna. But again, we don't know either. We're guessing.
This is Shane. I think that Johnson & Johnson's vaccine also has some efficacy concerns with regards to older populations. I think it's coming on at the right time as we get into the phases of the younger folks. But from a rural community perspective, where the average age of Columbia County, for example, is 50 years of age, 28% of the population is 65, really it's probably going to be Moderna and Pfizer reaching most of that older population here.
This is Ken. I guess I'd like to add a little comment about prioritizing. So currently, the plan in Washington is for hospitals or mass vaccination areas to vaccinate up to 50% of those eligible. And then when you get that 50%, then you can move on to the next, if you would, tier in phase 1B, which makes a lot of sense. Our experience with phase 1 was that there were a lot of folks that got vaccinated early, and then we personally experienced about a 2-week period where very few people in the eligible phase were getting vaccinated, and a lot of people in the next phase were, banging on the door. The problem that I see, and I guess a challenge to ask, is how are we as a hospital or even as a county, how are we going to know when 50% of the eligible population has been vaccinated so that we can move on to the next tier? So we're not in a position to individually decide who's going to get the vaccine. We're trying to follow the governor's allocation or prioritization schedule very carefully. But that part, I think, is eluding us into knowing when we can go forward with the next phase.
I think I've gotten through all the questions, unless anyone's got last questions for the chat, or feel free to unmute yourself and ask it. All right, you should now all have access to the Homeland Security fraud alert and the photos of the counterfeit masks. And we do have on our website updated data about hospitals' vaccines received and administered. We are planning for this to be the last week we collect it. We had said we would only do this for 2 or 3 weeks. As everyone has noted, there is so much, the data reporting requirements are very overwhelming. We wanted to share we thought that the data that was in Waze was totally not representing what was actually happening in hospitals. So we wanted to be able to collect and share that data. I think that's been really helpful to be able to see that that the vaccine that's come to hospitals has either been used or has appointments in order to be used. But we're not planning to continue collecting it just for the sanity of our members to not have to keep getting lots and lots of data requests. Beth is also noting that our next week's briefing, we do a briefing on Mondays. It's President's Day. We're going to move it to Wednesday at noon on the 7th. So our briefing will be at noon on the 17th. We'll send out an advisory about that as well. As always, thank you so much. Please continue to remind, even with your viewers and listeners and readers, even with vaccine, many more people getting vaccinated, we still need to all be wearing our masks, wearing better masks. You know, people should be wearing at least 3-layer cloth masks or a surgical mask. Keep your social distance. We're hoping that our antipathy towards Tom Brady will help us in the Super Bowl cases. You know, for folks who weren't from here, they deflated their balls, and we're still mad about that here in Seattle for our Seahawks. But we'll see. That'll be something we'll be able to report on in the next few weeks, is whether we see a spike in Super Bowl cases, but we sure hope not. So hope people will continue to be really safe, doing everything they can to be safe. We're excited about how vaccines are rolling through our state and excited about more quantity, and really hoping we can ramp up those efforts all across the state in the next few weeks. Thanks so much for joining us. Thanks, June, Dr. Dietrich, and Shane. Really appreciate having you as always. Take care. Bye.